Hello, this is Dr. Bhomik, and I am continuing with the lecture of pediatric thyroid problem. My last lecture was hypothyroidism, and mostly I talked about Hashimoto's thyroiditis or chronic lymphocytic thyroiditis. Today, I am going to talk to you about hyperthyroidism in pediatrics. And this lecture designed for medical student, senior medical student, pediatric resident, pediatric nurse practitioner, endocrine nurse practitioner, as well as endocrine fellows. So those who are following me already know who I am. So without further ado, let's go ahead with the presentation. So question is, what are the etiologies of hyperthyroidism in pediatrics? I like to divide it in two parts. Primary etiology, which covers the first cause of hyperthyroidism in pediatrics, and by that I mean is Graves' disease, which is manifested by diffuse toxic goiter. The secondary cause of etiology by far is very rare, but need to be mentioned, and that could be the toxic nodular goiter. It could be single or multinodular goiter. This is really uncommon in pediatrics. However, if there is a genetic factor and the children who has diagnosed with McCune-Albright syndrome, they are also known to have hyperthyroidism, and the cause of the hyperthyroidism could be a nodular goiter. In addition to that, there are situations where the patient has received radiation in the head and neck area. That will be another cause. And it has also been reported that if the patient is living in the area of iodine insufficient in the soil or in the water, they might develop nodular goiter. The next category is acute or subacute thyroiditis. An acute and subacute thyroiditis is mostly secondary to a viral infection, and this has been described before. So the reason they are hyperthyroid, that because of the inflammation and insult to the thyroid follicle, lots of thyroid hormone are released to the circulation in one time, and the patient present with the clear picture of hyperthyroidism, clinical picture of hyperthyroidism. And they are transient. Over the period of time, they become euthyroid. And the other one that we have talked a little bit in details in the discussion of Hashimoto's thyroiditis in my previous lecture, and that will be toxic phase of autoimmune thyroiditis, which is also known as Hashitoxicosis. Again, that is transient, but it could last for months, and eventually majority of the patient develop hypothyroidism, and I have discussed that in my previous lecture. So let's go back and look at the epidemiology of Graves' disease in pediatrics. Epidemiology of Graves' disease is pediatrics. The estimated incidence is approximately 1 in 10,000, where autoimmune thyroiditis is about 1 in 3,000, 2 to 3,000. So therefore, it's much less common than autoimmune thyroiditis. And like autoimmune thyroiditis, it tends to run in the family, and there is HLA connection, but the family history does not have to be positive for Graves' disease, but it could be positive for autoimmune thyroiditis, which I have also discussed in the lecture of Hashimoto's thyroiditis. Now, like most of the thyroid condition, it's also predominantly affect the female. It's about 4 to 6 times more common among the girls and the females, adult. And there is genetic predisposition, and the genetic predisposition is with HLA typing, and which we'll discuss a little bit in the next slide. And there is also other environmental factors. And in other words, we actually don't know. This is somewhat unknown, but is there. I personally like to know a little bit about the history of any disease. Beside medicine, I have a tremendous fascination for history. So anytime I see any disease in endocrine system or non-endocrine system, I like to know that how it was discovered, who was the first person and how it was discovered. So in this case, Graves' disease, I'm going to give you just a brief history. I do know that's not going to come to your exam or anything, but it's nice to know. We don't have to read everything because for the sake of examination, but let's learn something how our forefathers described this condition. It was first described by Dr. Perry in 1786 in Bath, England. Unfortunately, however, his work was published after his death in 1825, and so he really did not get much credit, which he should have been. Dr. Robert Graves in 1830 in Dublin, Ireland, described very nicely the clinical manifestation of Graves' disease. And he is the one who gave the name of TTT, tension, tremor, and tachycardia of thyrotoxicosis. And at present time, we all know the Graves' disease after his description. In Germany, however, in 1940, Dr. von Bessow described a very similar condition, which is Graves' disease. And in Germany and the literature there also they discuss as von Bessow disease rather than Graves' disease. But it's just what is in the name. Now, the very important area was Dr. Kocher from Bern, Switzerland, got Nobel Prize in Physiology in 1909, and he actually was a surgeon. By the time he got the Nobel Prize, he already performed more than 5,000 thyroid surgeries. However, he got the for Nobel Prize in Physiology is 1909. Well, there is another major step in the treatment of Graves' disease occurs in 1941-42, where Dr. Solhers from MIT suggested and used radioactive iodine as a treatment for Graves' disease in adult. Joseph Hamilton and Mayo Soley was the first to create radioiodine, both iodine 131 and 130 at Berkeley, California. So these are the tremendous discovery occurred in United States. So let's see what is Graves' disease. The Graves' disease is an autoimmune thyroid disease, and although it is less common than adult, it is less common in children than in adult, but it still is the most common cause of hyperthyroidism in pediatric age group as well. And there is a ACLA association with B8, DR3, and the association mostly noted in Caucasian people. However, this association has not been proven or has not found in African American and other races. And as you know, the ACLA association is with many other autoimmune disease like type 1 diabetes, rheumatoid arthritis, systemic lupus erythematosus, myasthenia gravis, etc. So if one has one disease, they are likely to have other one with higher frequency. So we do know that type 1 diabetes patients are more vulnerable to develop autoimmune thyroiditis or even Graves' disease and rheumatoid arthritis and so forth. So what is the pathogenesis of Graves' disease? If you remember in my last lecture on autoimmune thyroiditis, I did say that problem with Hashimoto's or chronic lymphocytic thyroiditis is primarily its problem with T cell, and failure occurs in surveillance T lymphocyte, and as a result of that, their cytotoxic effect of those cells occurs, and that I have spoken in my previous lecture. But here, right here in the Graves' disease, the defect primarily involves the B cell. And these B cell differentiate into plasma cell and produce thyroid stimulating immunoglobulin or thyroid receptor antibody, which is pretty same, the very two different name. And this TSI or the receptor antibody binds with TSI's receptor. It not only binds with TSI's receptor, it actually replaces the TSI's receptor, kick them out from the receptor site, and stimulate the thyroid gland and make them produce continuously uninhibited thyroid hormone. So it does not follow the rule of that what the TSI does. When you need more thyroid hormone, it will produce thyroid, And when there will be more thyroid, there will be a positive feedback, and then it will suppress the formation. That check and balance system is gone. Therefore, thyroid gland also get bigger because it has to work hard and produce more T4. So result is excessive production of T4. However, if you do check those TPO and anti-thyroglobulin antibody, majority of the cases will have some of that antibody, albeit in low titer or low concentration, but they could be there. So clinical manifestation of Graves' disease, as I have mentioned, triple T of thyrotoxicosis, tension, tremor, tachycardia, voracious appetite but weight loss, and exophthalmos is usually mild in children, but it could be very severe also, especially in black children. They have smooth skin, muscle weakness, and they have increased pulse pressure, and that's because of increased systolic and decreased diastolic blood pressure. They have polyuria, especially noted at night, because hyperthyroidism increased the blood supply to the kidney almost by 13 times. So GFR goes up, so they have to go to the bathroom. And can't sleep well because of thyrotoxicosis, or they have to probably go to the restroom a lot. Goiter is almost always present, which is not a true statement all the time in chronic lymphocytic thyroiditis. Here I have the typical Graves' disease picture. This is a Caucasian girl. She does have a goiter. Here it's like symmetrical enlargement of thyroid gland, which is diffuse. And also she does have a little bit of exophthalmos, or it can be called as lead lag or mild exophthalmos. However, this is an 18 years old African American girl who has not only Graves' disease but a severe form of exophthalmos. As you can see, the eye is protruding. There's such a big gap in the both sides, and this is a big problem, not only cosmetically, dry eyes, and many a time they might need help with surgery. And people have used steroid, but surgery can alleviate some of this problem. So if you go to the laboratory studies, you can, preferably we do free T4, T3. One can do total T4 and T3, which is not very commonly done nowadays with TSIs. The additional diagnostic test is going to be thyroid stimulating immunoglobulin or thyroid stimulating antibody. It's a good idea to check thyroglobulin and microsomal or TPO, which is microsomal antibody, thyroid peroxidase, and a baseline CBC with differential and liver function test may be worthwhile, because depending upon the treatment, if you are going to use medicine, then the blood count and LFT check is as a baseline is worthwhile. But radioiodine uptake and scan is done specifically if there is a questionable diagnosis. You have to see the high uptake hyperthyroidism or if you are contemplating to use radioactive iodide as a mode of treatment. So you need the uptake to see the functionality of thyroid gland and the scan to see the size of the thyroid gland so you can calculate the dose. The treatment of Graves' disease, we have got three modalities of treatment: medical, surgical, and radioiodine. I'm going to discuss all of them briefly. Medical treatment is time-honored treatment. In my time, I have used many a times, is PTU. PTU have distinct advantage that not only it blocks the organification, thyroid peroxidase enzyme, but it also prevents the conversion of T4 to T3 in the peripheral level, and severe hyperthyroidism, that is a good idea. However, this is not used as a first line of drug in the United States, Europe, and Australia because of the toxic effect on liver. And the dose is about 5 to 10 milligram per kg per 24 hours. And another disadvantage, I believe, is you really have to give 4 times a day. And imagine that most of the time we're talking about the Graves' disease that occurs in teenage group. Now then, how often a teenager is going to follow the protocol of taking the pill 4 times a day? Not to talk about teenager, I will have hard time to take any pill more than 2-3 times a day. However, the most commonly used antithyroid medication in this country is methimazole, which is known as tapazole also. And the dose is about 1/10 of PTU. And it can be given 3 times a day. The another distinct advantage of methimazole is that if your thyroid function is improving and the patient dose can also be decreased from 3 to 2 times and maybe once a day as well. And so it is preferable that way. The duration of the treatment, if you read the standard textbook, they will tell you 2 to 4 years. This is so difficult to predict. Those who have taken care of many more patients with Graves' disease, they will know you are lucky if that statement holds true. Especially in the younger one, if you do stop it early, even when thyroid function is normal, they will be back. As you know, the recurrence rate of Graves' disease is higher, even with the best protocol. So, one of the way to do it, that once the thyroid function has become normal, then look for thyroid antibodies. If they have disappeared, I mean TSI, thyroid stimulating immunoglobulin, then you might consider discontinuing the methimazole. However, you must follow them very, very carefully. As I said, recurrence rate is high. At some center, and I have done some time also, especially the patient with Graves' disease with Down syndrome. Actually, I published that one in Southern Medical Journal long time ago. And that they do better, that even they become euthyroid, and if their TSI level is still detectable, people have used the combination therapy. Methimazole with a little bit of levothyroxine or thyroxine, and so they will not be hypothyroid and wait until the whole TSI or thyroid receptor antibody is gone. And beta adrenergic drug is a vital, and that should be started from the very beginning, and that should be adjusted depending upon the heart rate and the patient clinical symptomatology. And those who are on methimazole or one of the oral medication, their CBC with differential and liver function should be checked off and on. Now, one thing an experienced endocrinologist will tell you that even the patient is having normal CBC, good liver function, but the critical time to check the CBC and differential is if the patient is sick with fever and sore throat. If the patient is sick and sore throat, the endocrinologist will tell them to get a CBC and differential count. Although we know the most common side effect of methimazole or PTU is skin rash. Most common. However, most dangerous, but not common, most dangerous as agranulocytosis. And that is dangerous, and that seems to occur when the patient is sick with sore throat, fever, and not feeling well at that circumstances. Surgical treatment, when the failure of medical management, and most of the time it is because of compliance. Before you send the patient to surgery, one has to make sure the patient is in euthyroid state, and one need to give glucose iodine or SSKI 5 to 7 drops for 10 to 14 days to decrease the vascularity of thyroid gland, because as you know, thyroid gland is very, very vascular and it tends to bleed a lot. And always try to find the most competent surgeon who is doing many of this kind of surgery. And be aware of complication, but those are just for the, I'm going to tell you, just like paralysis of the vocal cord because of severe cutting of a recurrent laryngeal nerve, hypocalcemia if the parathyroid has been removed, and those are actually a rare complication, and it is not a big problem if the operation is done by an experienced surgeon. Now let's talk about radioiodine. Radioiodine treatment for Graves' disease in children was more or less a taboo for a long time. When early in my practice, I have been always in academic medical center, and I have worked with quite a few endocrinologists in the division, and I used to follow the party line that will be start with antithyroid medication and follow them and continue for years and other. Then as the time progresses, and I was convinced that radioiodine in treatment of Graves' disease is very effective in children. And this can be used even the first line of treatment. Now there is a difference of opinion. Some people are still conservative and they do not like radioactive iodine. Some people would like to use after a female patient has started their period. So I'm not going to argue with any of that. And I'm not saying that I am right and they are not right. But I personally prefer in teenage group, if there is no contraindication, one of the contraindication relatively was very big, exophthalmos. And radioiodine is used. And the dose is, many center is calculated by nuclear medicine after doing the iodide uptake and scan. I used to do my own calculation. But I think that I'm going to tell you something that probably many will agree, is that when you calculate the dose, try to use the upper calculation. So if it is turned out to be 10 to 15 or 15 to 20 microcuries, use the top one, because it is always a good idea to use one time and let the patient develop hypothyroid, be it in 6 months or 1 year. And we do know that one of the clinical consequence of reducing radioactive iodine, that they eventually will develop hypothyroidism, and that is actually the goal. And once they develop hypothyroidism, we have to replace them with thyroid hormone. So it has been a great achievement in the field of medicine, I would say, and I do use radioactive iodine as a first line of treatment in many cases. Do discuss with the family, and still some of them are a little worried about the ramification of the treatment. But those who do not want it, clearly I don't force them. I tell them we'll treat in the other way. So other causes of hyperthyroidism is toxic nodular goiter, rare in children. As I have mentioned, that it could occur after the radiation in the head and neck area, or it could occur as a part of a genetic factor. And usually a surgical treatment is necessary to remove those. Fortunately, we don't see many of them. And subacute phase of thyroiditis, use beta blocker to prevent the untoward symptoms of hyperthyroxidemia, and usually it's transient and will go away. Toxic phase of Hashimoto's thyroiditis I have discussed in my previous lecture, and it nodule, that pathology could be a toxic nodule, which could be a hot nodule, and that can be treated by surgery. Some people has used in adult radioactive iodine because the concentration of the iodine will be in that hot nodule. In pediatrics, however, there is one condition is pretty interesting, and I have seen few. Factitious hyperthyroidism. As I have discussed before, that I was also in charge for 5 years the pediatric weight management clinic. I have seen quite a few, especially the teenage girls, they're taking their mother's thyroid medicine because they are told that thyroid will help them to lose weight. So how do you know, how can you differentiate that if she is vividly disagreeing, she or he? Well, there are a few tests you can do. First of all, if you measure the T4 and TSH will be suppressed. However, you also measure the serum thyroglobulin, that will be suppressed because this T4 is coming from outside. But if you go a little bit further, do the iodide scan and iodide uptake will be low, very low, and scan will not be a heart scan. The gland size is completely normal. And obviously treatment is to get rid of those thyroid hormone injection they are doing. Thank you very much, and I will see you in my next lecture. I think before I put my next lecture, I might go through 20 board questions.